Welcome to Doctors on Call. I'm Jenna Miller. We are well into the cold and flu season, but how do we know the difference between strep throat, the common cold, or even COVID? It's a new year. Do you have any new goals to lose weight and be more healthy? We'll tackle these issues and more on Doctors on Call with our guest family physician, Dr. Tyrel Summers.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from Camco, the state's only Kansas-based medical liability provider, serving medical professionals and advocating for the health for all Kansans.
Russell Regional Hospital, experts, neighbors, friends.
Your family is our family. Staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.
Dr. Tyrel Summers received his medical degree from the University of Kansas School of Medicine in Kansas City. He completed his residency at the University of North Dakota Center for Family Medicine in Bismarck, North Dakota. Dr. Summers is board certified through the American Board of Family Medicine and is a member of the Kansas Academy of Family Physicians, American Academy of Family Physicians, and the American Medical Association. His professional interests include chronic care management, gastroenterology, pain management, and psychiatric disorders. Dr. Summers has been affiliated with Russell Regional Hospital since 2015. Our phone lines are open at 800-337-4788 toll-free if you have any questions regarding general health on today's show. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much for kicking off our new season of Doctors on Call. Let's go ahead and start with some questions. First of all, we're kind of in the thick of all kinds of seasons right now. How do you know the difference between the flu, cold, RSV, COVID, all of that?
It can be really, really challenging at times to know the difference between different viral illnesses, and that makes it really, really challenging, not just as a parent, but as a patient and also too as a physician to discern between all of those different things. By far the most common thing that we see with these types of illnesses are like a runny nose, a sore throat, a cough, fever. All those are pretty classic between all the different types of viral infections. One of the ways that we can differentiate between them is some of the secondary symptoms that you can have. So like headaches, muscle aches, joint aches are sometimes more a hallmark of influenza, though sometimes you can see it in other infections as well. Specific types of cough, like a wetter cough is normally with like RSV or with COVID-19. There's different kind of symptoms and things like that. The most important thing though is our advances in technology now allow us to do what's called PCR-based testing, which are very specialized types of tests that we can collect sample, normally from the nasal septum of patients within the pharynx there, and collect the sample and send that over to a lab to be analyzed. It can then tell us what type of viral illness a person's suffering from, and that can be important in determining what type of treatment to give to a patient.
The PCR test, is that nasal swab? What kind of test does that include?
Yeah, so as of right now, it is currently a nasal swab that we use for testing, at least at Russell Regional Hospital. There are some other facilities that are experimenting with oral pharyngeal swabs, where they can collect a buccal sample from like the cheek kind of area with saliva. But for the most part, the standard in kind of Kansas has always been the swab that goes into the nose and always feels like it's tickling your brain, unfortunately.
And why is it? That's a question I have a lot of people ask. Why do they have to go so far into the nasal cavity?
So when we go into the nasal cavity to collect that sample, what we're looking for specifically is we're looking for a high kind of marker of viral kind of count that's there. That's very, very much high in the area where mucus is produced, which is kind of in the posterior part of the nose itself. And so we have to go in about 6 centimeters, which is about 3 inches to kind of get a good sample. Unfortunately, the best way to kind of assist is to lean your head back when you're getting the test and then allow them to kind of place it in. And then as they're bringing out, don't blow hard, but blow very slightly in through your nose. That allows us to collect a little bit better of a sample so that we can send it off for testing.
Do you find patients will come in with a virus of some sort and just think they can be prescribed an antibiotic and be done? How does that work?
Yeah, that happens quite frequently, that individuals come in very early on in disease and they're thinking, oh, I just have a simple bacterial infection or a sinus infection. And while that might be true, we always want to make sure that we understand that bacterial infections are normally secondary infections to these types of illnesses. And so there's something that kind of happened after the initial viral illness. Now, there are some individuals who are much more prone to bacterial infections, in which case their physician, who knows them very well, should be able to discern that and will give them an antibiotic a little bit sooner than most folks. But the rule of thumb normally is if you got an illness and it's lasting anywhere between about 5 to 7, 8, 9 days, most of the time that's a simple viral illness that should pass on its own, which is symptomatic treatment, like taking medications over the counter, controlling fever with Tylenol, using medications to help with a cough, those kind of things.
And why can't you just prescribe an antibiotic and be done with it?
So you definitely can prescribe an antibiotic. There's no harm in giving a patient an antibiotic in that specific case. The problem is the antibiotic really isn't going to help what's going on. Because it's a virus that's causing the illness, an antibiotic really doesn't target it. And that antibiotic can then cause problems with your bowels. You have a very specific type of microbiome within your gut, which is the specific bacteria that live there. If you give an antibiotic to that, it kills that. And when it does that, it can cause problems with like diarrhea, it can cause problems with upset stomach, it can also cause problems with your immune system in the long run. The secondary reason why we don't just want to give an antibiotic to someone with a viral infection is you can breed infections then that become super infections, which means they're resistant to a lot of antibiotics. And so you have to be very careful when you give a patient just antibiotics without any kind of recourse, because you can cause problems in the long run for them, unfortunately.
You mentioned RSV earlier. What is RSV? We hear it's being very risky for children. Can it be serious for older people as well?
It's a wonderful question. RSV is short for respiratory syncytial virus. It's a virus that lives primarily within the lung tissue as well as within the nasopharynx of an individual when they get infected. It's very, very harmful to younger children, especially those under the age of 2, where it can cause problems with breathing to the point where they just have a hard time. They need assistance, in which we can give medications and things. Sometimes people have to even be hospitalized for that. This most recent bout of RSV, though, because of other infections going on, has been a little bit more harmful even to older kids, as well as some adults and elderly population as compared to what we normally expect for the RSV season. It's a lot earlier, too, to be seeing RSV. The normal peak time is about February, and we were seeing cases as early as October, November this year. We're still seeing the occasional case of RSV, but it hasn't been nearly as frequent as influenza and COVID-19 recently.
Do you expect that you'll still see a big wave in February, or do you think we've kind of gone through it?
I honestly think we probably have gone through it with us kind of having a little bit earlier of a season. Most of the time when we see like innate immunity, people who have natural immunity to a disease, it's normally anywhere from about 3 to 6 months after they have the disease that they carry antibodies on forward. And so those individuals that were sick in like November, kind of October with RSV likely won't get RSV in February as expected. And so it probably won't hit nearly as hard in February as it did in November. Though there is a possibility that those that weren't infected during November do catch RSV in February as normally predicted and expected.
And at what point should a parent get their child to the hospital?
Yeah, so it's really important to watch for very specific hallmark signs in RSV, because there's some that can cause problems for a child. The first and most important thing is to watch for cyanosis, which is a blue discoloration that can happen anywhere within the skin. The most common spot is kind of around the lip area itself, but it can happen in the fingers, it can happen in the toes as well. That's normally a sign that oxygen levels are starting to drop in the individual. The next thing is their breathing specifically. If they're using their chest wall a lot, so breathing very, very heavy, being very, very kind of belly breathing is what we kind of say sometimes too. That can also be a sign that a child's struggling as well. A cough isn't necessarily something that we see that we worry so much about. In fact, children that are normally coughing with RSV are kind of clearing out some of those secretions, and that's a really good thing. One of the things I tell a lot of my parents that are kind of struggling with RSV with kiddos is the importance of using like warm humidified air. When you can get a child in an environment where there's warm humidified air, like a shower or bath area, that kind of helps loosen up some of that mucus. And then when they go from that over to a colder area, it kind of helps open up their nasal passageways so they can breathe. So whenever you have a child who has really any kind of upper respiratory illness, but specifically RSV, you can try that trick, and sometimes that's really, really helpful to allow them to get a few, like 30 minutes, 45 minutes of respite from all the coughing and from feeling terrible.
Switching gears a little bit to COVID, what are you seeing in COVID cases right now?
So our COVID cases over the last 3 weeks have been increasing, at least in Russell County specifically. Kind of everywhere within the state, like we had a little bit of an uptick towards the beginning of October, middle of October. It's semi-plateaued around November, but has just continued to kind of go up. Surprisingly, we haven't seen as many COVID mortality rate. Like that rate has kind of gone down, meaning people are not dying nearly as much from COVID as they were previously. I attribute that to first natural immunity, but also to vaccination. vaccinations. Those two things in combination probably are helping. On top of that, too, we have a brand new medication that we give people that's an antiviral medication specifically to COVID that goes in and takes care of the virus earlier and produces kind of this antibody against it so that it reduces spread of the virus. Because of those three things, that's probably helped out significantly, reduce both the mortality rate as well as the overall risk rate associated with COVID-19.
And what is the CDC? I know it's ever changing. What are they recommending right now as far as if you have symptoms, when you're actually tested? What are they saying right now?
Yeah, so they're still recommending to have testing done pretty soon, especially if you're early in the course of symptoms. They say anywhere between about 24 to 48 hours after you begin having symptoms, which can be runny nose, sore throat, cough, any of those things. There's a plethora of at-home tests that work very well if they're used correctly. The most important thing is to make sure you read the directions because every manufacturer's test is a little bit different. But it's very similar to like a home pregnancy test where you look at a little slot and it will have different colors that are available. It's a very good way to test in kind of an early screening to kind of see if you have COVID or not. I would not 100% rely on home tests to say for sure that you don't have COVID. If you're still having symptoms or you're around someone else that tested positive but you had a negative home test, I would still encourage you to maybe seek out like a hospital or a clinic that has access to PCR testing. It's a little more definitive in telling a person for sure if they have COVID or not. The biggest thing though is if you think that you have any kind of illness or COVID, you want to make sure that you're testing early so that you can keep yourself at home and reduce the spread of disease and the spread of risk. And the spread normally is anywhere between about 4 to 6 days is the maximum time frame that you need to kind of stay at home to allow yourself time to recover, and that will reduce viral shed to help reduce the risk of passing on infection to other individuals.
And just so you're not confusing the pregnancy test with the COVID test, correct? Yeah.
Completely different test, yeah. A pregnancy test is done by urine test, whereas a COVID test is done by nasopharyngeal swab.
Okay, good to know. Have you seen patients with lingering symptoms that maybe still have symptoms even though they had COVID a couple years ago?
Yeah, absolutely. Yeah, long haulers COVID or COVID syndrome is a very, very prolific disease that's occurring right now. There's some individuals who have problems with breathing for months to years after they're having infections with COVID. We're starting to see people that are probably going to have like long-term ramifications like chronic obstructive pulmonary disorder or emphysema from COVID. There's some people too that still have problems with like their taste mechanism, with like smelling because of COVID. There's some people who have problems with like profound weakness after COVID as well. I've had people that have had complications to even like some COVID interventions. At the very beginning of COVID, we were using like high flow oxygen to help people breathe. We've had people who've had complications because of using high flow oxygen. Unfortunately, because it's something that is still relatively new and we're still learning things, we're attributing more and more to kind of what we learn about COVID and long haulers COVID syndrome. And it's likely if you're having problems even post-infection months and months later, there's a chance that COVID could be causing some of those complications.
We want to remind our viewers that we're talking about general health tonight on Doctors on Call with Dr. Tyrel Summers from Russell Regional Hospital. You can give us a call at 800-337-4788 if you have a question. Let's talk about ways to avoid catching an infectious disease.
It's really important to do several different things if you're trying to avoid disease. One of the things I find primarily that helps out is to keep your hand hygiene as well as you can. Make sure that you're washing your hands, especially when you're in close contact with public surfaces. If you go to like a restaurant or you open a door or anything like that, make sure you have access to somewhere where you can clean your hands off, whether that be with soap and water, whether that be with like an alcohol-based product. Either of those things are great in helping reduce the risk. Second thing is avoiding the T-zone, which is a very specific area in your face. That's right along your eyes and then down front. Those are the passageways where a lot of viruses come into, so making sure you're not doing as Dr. Summers is doing right now, like touching your face often without cleaning your hands beforehand. Another way is to avoid individuals that are sick. So if you see someone that's sick, trying to keep your distance. If you remember initially we were saying, 6 feet kind of social distancing was important with COVID-19. While that 6 feet hasn't really panned out to be fully what's going on, trying to keep your distance from individuals that are sick or staying home when you're sick yourself can reduce the risk of spread of infection too. So all those things are very helpful to make sure. Those are by far the most important things that you can do to kind of avoid infection risk.
Is there any truth behind, you'll hear that the hand sanitizer, you can overuse it. Is there any truth behind that?
Not that I've ever seen or anything that's done. By far the only problem with hand sanitizer, because it contains alcohol normally for cleaning, is it really dries out people's hands. So I'll see more people for chapped, kind of dry hands and complications from that because of overuse of hand sanitizer. But it's not like you're going to clean your hands to the point where you kill off all of your good bacteria on your hands. You'll always have bacteria on your hands regardless. You're just minimizing the risk of those bad bacteria going from your hands to other areas on your body. So no, it's completely safe to use hand sanitizer.
I don't know about you, but I hear a lot of people coughing right now. So what causes a cough?
Yeah, so a cough can be caused by a bunch of different mechanisms, which makes it really, really tricky. In upper respiratory infections, there's two main things that cause a cough. The first thing is postnasal drip, which is gross sounding, but basically what it is mucus that goes from the very back part of your nose and then drips down your throat and into the very top parts of your oropharynx. When that happens, it triggers a cough reflex because it's trying to prevent it from getting into your lungs and getting into your stomach, basically. That's a pretty common way. When you cough when you're laying down, that's a very, very common way that you'll cough. So what people that struggle with a cough at night primarily might be dealing with postnasal drip symptoms, or if like it's positional, so if you lean your head back, or if you're sitting a very specific way and you start coughing, that's probably postnasal drip. Postnasal drip isn't just from upper respiratory infections though. There are other things that can cause it, like people with allergies that have a lot of a cough. That can sometimes happen because of postnasal drip as well. The second reason why people cough in upper respiratory infections is when it becomes bronchial in nature, which means that it goes down within the lungs proper. When you have like a bronchitis or you have a pneumonia, what happens is there's very small hairs within the lungs that help clear out junk. They're called cilia, and they help take care of mucus, dead cells, all sorts of gross stuff as well. When they become irritated or they become overburdened with mucus, your body's reflex is to stimulate a cough reflex to help clear all of that stuff out, to hopefully help you get breathing more comfortably and breathing better.
And what are some of the solutions, whether it be medication, other solutions to calm that cough down?
Yeah, so by far, some of the things that help with the cough, it really depends upon what's causing it. In the case of a postnasal drip cough, positioning is very helpful. Some of the over-the-counter things to help kind of reduce mucus kind of thickness are helpful, so like Mucinex. For some people, dextromethorphan is kind of a cough suppressant, and it helps. People don't like it too, and that doesn't work for some people, and that's fine. A cough drop sometimes helps with that because it helps soothe kind of both the oral pharynx itself. It doesn't really numb it, but it helps make it not as prone to irritation so you don't cough as much. That's why you see during this time frame people just taking so many cough drops down and down and down and down. It seems to be helpful with that. With the bronchial cough, it's a little bit trickier because it's much deeper that it's causing the problem. Again, guaifenesin and dextromethorphan do help a little bit with those things, but by far the best thing is medications. So the medication albuterol is a really good medication treatment for bronchial coughs because it helps open up the bronchioles itself specifically by how it works. And so that allows more mucus to come out. It allows you to clear it more effectively so you're not coughing nearly as much.
Sometimes you'll hear a person cough and then they'll make sure and say, well, I'm not contagious. Is there any truth behind that?
Oh, absolutely. Yeah, there's definitely individuals that can be sitting there coughing and coughing and coughing, and they're at no risk for causing any kind of disease. As I kind of mentioned when I was talking earlier about COVID and other things, the very infective part is kind of right as you're getting symptoms, and then for the very first few days of symptoms. After that point, you're not really as infectious. What you're dealing with is secondary complications of the illness. You're not producing really enough viral particles to shed that can infect someone else. So some people, especially this specific round of infections, have had prolonged coughs. I myself have been dealing with a cough since about the end of November. That's just been off and on for the last few weeks. I'm not infectious, not contagious at all to anybody, but every now and then I'll just sit there and cough and cough and cough. There's nothing that can be done about it other than giving medications for treatment of the cough. But I also have to tell people, look, I'm a doctor, I'm sorry. You might think I'm going to give you something, but I'm really not. I've kind of cleared this infection a while ago. I'm just dealing with complications from it.
Good to know. We're going to switch gears again. Why is it important to know your family history?
Yeah, so a family history is exceptionally important, especially to a clinician, to kind of determine your risk factors for certain types of disease. So getting a thorough and kind of full family history, if you can, is really important. Talking with your parents, talking with your siblings, your grandparents to find out kind of what diseases they had can lead a clinician towards kind of certain testing and certain thinking on an individual that we probably wouldn't think normally. For good example, when there's a high factor kind of risk for diabetes in a family, I'm much more prone to check glucose levels on a patient than I probably would on normal patients because I know there's that risk factor that's there. If you have a family history of coronary artery disease, we often screen you for lipids a lot more thoroughly. We look for heart disease a lot sooner. If you come in saying that you're having chest pain, we're much more likely to work that up and evaluate it if you have a family history of coronary disease. So it's really important to understand your risk factors that are associated with your genetics that come from your family history. And getting that information and sharing it with your clinician can help them make the best determinations and decisions for your health.
Is there a way to change the course of genetics?
That's a great question. Genetics are kind of what you're stuck with when you're born, and so there's not really anything specific that can be done to change your genetic risk. However, if you do have a higher risk for certain types of diseases, you can do things to help minimize that risk. I'd mentioned just a minute ago about coronary artery disease, and if you do have a family history of coronary artery disease or heart attacks, you're at higher risk for them, obviously. But if you do the things that you need to control your cholesterol levels, to keep yourself healthy, to exercise regularly, you're going to reduce that risk compared to another individual that doesn't do those things that has the same family risk. So while you can't change your genetic risk, you can change your overall risk by doing the right things to help minimize those genetic risks against you.
Talk about swelling in the body. What causes swollen ankles and feet?
Yeah, so swelling within the body can be caused by a bunch of different things. By far the most common thing during this time of year is what's called venous insufficiency. Venous insufficiency, the fancy way to think about it is that your veins in the very far parts of your body are not pulling in fluid like they should, and they're also not holding on to it like they should. Basically, as individuals get a little bit older, their veins get lazier, and they don't pull in that liquid like they should. And so it ends up pooling in areas where there's high protein, which is your muscles and your skin kind of and subcutaneous tissue. And so you start to get swelling in your feet, sometimes in your hands, all sorts of other problems or other places. However, if you do have swelling in those places, don't always attribute that to venous insufficiency, because there are underlying diseases that can cause swelling that need to be investigated, that need to be evaluated. For example, congestive heart failure is a very abnormal case of problems that can cause swelling, where if you do have congestive heart failure, treating you for venous insufficiency may not be beneficial to help fully get rid of your swelling, and you might need further treatment of your congestive heart failure. Thyroid disease can also cause swelling. Problems with protein intake can sometimes cause swelling, as well as a myriad of other diseases. So all because you do have swelling doesn't mean that you should just ignore those warning signs and say, oh, I just have leaky veins and don't see a physician. You should always see a clinician so that they can help kind of determine what's causing your swelling and help you treat it effectively.
Okay, we're going to go to the phone lines. We got a little bit of time left in the show. We're going to talk to Janet from Hayes. Hi, Janet. Go ahead with your question for Dr. Summers.
Yeah, I was told that I have what they said is dense breasts on my last mammogram. Does that mean I need a special kind of mammogram next time?
So that's a great question. I heard that you had a mammogram that showed some signs of kind of some abnormality on one side compared to the other. At least I hope that's what you said. Yes, normally once we find an abnormality within a mammogram, we want to do further testing with very specialized treatment or very specialized studies on that specific side. Sometimes that's spot compression, meaning that we want to get kind of a much more dense picture in that area with a mammogram. Sometimes we use ultrasound if you have very dense breast tissue. Sometimes we use very specific types of views to look at it. So for example, when you do a mammogram, it's a top-down view, and sometimes we want to look at it horizontally. Sometimes we want to look at it at an angle. And so we'll kind of change the way that we're looking at things based upon where they think the lesion is on your breast, and they'll use very specific studies then. If something still looks abnormal with those special studies, the next step normally is getting what's called a fine needle aspiration, which is like a biopsy needle that will go into the area where the abnormal tissue is and collect a piece of that tissue. We can then look under the microscope and see what is occurring with that specific type of tissue to see if it looks like it could be cancerous or not, because that's really what we're concerned about in a mammogram, to make sure that we're not missing. But thank you for your question. Very good question.
And how often do they find the mammograms that a spot might be cancerous compared to when it's not?
Yeah, so mammograms are recommended for women over the age of 40. They should be getting it at least every 2 years. I see maybe like once a month an abnormal mammogram come across my desk personally, where we need to do more kind of studies to kind of check things. Most of the time they come back normal. Like, it's just that we needed a different view to make sure. I would say that probably once every few months I get someone who has to go get a fine needle aspiration, and then probably once or twice a year I catch someone who has breast cancer. The great news is breast cancer is much more treatable today than it was even 5-7 years ago when I started going through medicine. There's new treatments that have come out that are anti-biological, that work very specifically for very specific types of cancer. And that's with most cancers now. The field of oncology has exploded in its treatments and how they take care of people. And so if you think that you're having issues, if you think that you have concerns about a mammogram or even other cancer screenings, please talk with your clinician and they can get you taken care of.
And you mentioned a person turning 40. What can a person do? That seems like a magic number for some reason to help their health after they turn 40.
So the biggest thing to know when you get to the age of 40 is that you do increase in your cancer screening. Prostate cancer, breast cancer, colon cancer screening all kind of begin around that time frame. Now, that's not always the case. Colon cancer normally begins at 50, but if you do have a high risk or a family history of it, you might have to do it sooner. And so it's really important to know those kind of things. But there are some things you can do at 40. By far the most important thing, see your clinician every single year for an annual visit. That is by far the biggest thing that you can do to change your health. If you want to do something to make yourself more healthy, to make yourself more likely to not end up with a disease, is to see a doctor every single year. They'll recommend different screening tests, they'll recommend different laboratory tests, different respiratory tests, radiology tests, based completely upon what your history is and based entirely upon your risk with those annual visits. So if there's one thing you can do, do that. The next thing is take care of yourself. All because you're 40 doesn't mean that you don't get to enjoy your life. Go out and have fun. Go out and exercise. Go out and take care of yourself. Eat the food that you should eat. Don't eat the stuff that you're not supposed to eat. Those are really important things when you're 30, let alone when you're 40. So keep doing those simple things. But I would encourage anybody that's over the age of 40 that's looking on changing their health, make an appointment with your clinician. Go see them. Talk to them about your overall health and your risks so that you can get taken care of.
Thank you so much, Dr. Tyrel Summers from Russell Regional Hospital. Our next Doctors on Call will be discussing pet health. You can email questions at doctors@shptv.org. Thank you for joining us. For Doctors on Call, I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from GAMGO, the state's only Kansas-based medical liability provider, serving medical professionals and advocating for the health for all Kansans.
Russell Regional Hospital. Experts, neighbors, friends.
Your family is our family. Staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in North Central Kansas.